Hello, and welcome to the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division of Aging Services. Before getting started, we advise having a pen and paper ready to write down any information and links to the resources as they are provided. Otherwise, you will have to view the webinar again to retrieve it later. You may pause the webinar now if needed. Remember that the link to the SurveyMonkey post-test will be pasted onto the last slide. The post-test will remain open for an indefinite amount of time. Please take it at your earliest convenience, though we encourage immediately following the webinar. A certificate can be provided when entering your email address at the end of the post-test. Today's webinar will be Recognizing Risk Factors, Service Providers, Signs of PCI and MCI, presented by Dr. Kathy Dial. Dr. Kathy L. Dial, PhD, has spent her entire career in social work. She has over 25 years of social work experience in direct practice, group work, grant writing, teaching, advocacy, program and policy development, and program evaluation in both child welfare and geriatric settings. Her expertise lies in the areas of gerontology, kinship care, grandparents raising grandchildren and relative caregivers, and child welfare services. She is currently the CEO for Kin & Kids Consulting, Executive Director for Kids Kin Caregivers, and is an adjunct professor for the Ethlyn R. Strong School of Social Work at Norfolk State University. Dr. Dial graduated from Idaho State University with a Bachelor's of Science degree in social work. She received her Master's in Social Work with an emphasis in Aging and Administration, Community Organization from San Diego State University, and her PhD in Social Work from Norfolk State University. In addition, she has completed graduate hours in community health education and has a faculty development certificate in geriatrics from the Virginia Center of Geriatrics at VCU. She is a certified trainer for program leaders for the Rosalind Carter Institute's Caring for You, Caring for Me program, and a certified interventionalist for their RCI REACH, standing for Resources for Enhancing Alzheimer's Caregiver Health program. She currently serves on the board of directors for the Virginia Caregivers Coalition. Welcome, Dr. Dial.
Thank you. So today we're going to talk about recognizing the risk factors for PCI, pre-cognitive impairment, and MCI, mild cognitive impairment. But first, before we talk about those two topics, let's look at what happens as we age, looking at memory in regards to normal aging. Now, we all know we have physical declines as we age, but we also have declines with our memory. So science and research has identified several areas of decline. One is we have a delayed free recall, which means once we get older, it's harder for us to remember things quickly, spontaneously, without some type of cue. As the slide shows, the best example is going to the grocery store thinking, oh, well, I need coffee and bread and eggs and sugar, and we walk in and we don't have a list, and as we walk through and we check out, it's like, now did I catch everything? And when I go home, I didn't have it. So we're needing a cue. The second is we have difficulty with our source memory. We're very knowledgeable of the information, but we're not sure where we saw that fact. If it was our best friend, if we read it in an article, if we learned the information on TV. So that's our source memory. The third area that we have difficulty with as we age and it declines is known as prospective memory. It's remembering to perform intended functions in the future, such as remembering to take our medicine before we go to bed. In addition, research shows that as we age, we decline in the speed for information processing. It just takes us longer, which means when we're looking at different things, we're trying to figure it out. We decline in the speed of executive functioning, our working memory, switching among tasks. We can't always juggle 3 or 4 things anymore. And then we've noticed sometimes as we age, our inhibitions lessen and also our capability for reasoning. Let's move on to see what stays stable with age and what things remain stable. There are three very strong areas that remain stable: recognition memory, temporal order memory, and procedural memory. Now, when we're looking at recognition, is that we're able to remember things and retrieve it when giving a cue. Someone's talking to us, giving us yes or no questions, and we're able to continue to relate a story or something that happened to us in the past or currently. The second one is temporal order memory, memory for the corrective time or the sequence of past events. For example, last week we had lunch, we went and saw a movie, and then we went to dinner with our best friends. So we can remember those things step by step, the sequences. The third and final part of memory that remains stable is our procedural memory, which is memory on how we do things. Many of us remember riding a bike. We learned as a child, provided with a bike at this age, as we age, we're still going to have that same skill. We're going to remember how to continue to ride that bike. So these are the things that stay in place. So as we age and we notice some changes, we can say, well, how do those changes compare to what's normal for remaining stable and what things really decline? So let's first now look at the definition of pre-cognitive impairment. This is a relatively new term. Some of you may know hear of it more as preclinical. It is looking at the clinical guidelines for the diagnosis of dementia, which is really symptomatic prior to being able to have it diagnosed. As we know, the pathophysiological changes in our brain change as the process of Alzheimer's begins, and this happens many years before we even notice the symptoms outwardly. It can be years and even decades before we get a clinical diagnosis. So due to medical advances and scientific advances, we could look at these pre-cognitive changes using neuroimaging. We can use cerebrospinal fluid analysis and looking at other biomarkers. And there are some other areas that we look at. One is there an evidence of any amyloid accumulation in the brain? Second is that there may be some very subtle cognitive changes in our bodies, or declines or alterations that the individual may be able to identify but is not detected by others or the physicians or by diagnosis. And thirdly, it also provides us with an opportunity, if we're looking at defining pre-cognitive impairment or doing a diagnosis, that if we are diagnosed, we can rule out other health conditions that provide us with similar symptoms of dementia. So overall, let's go back and review. The definition is looking at the preclinical stage. There are biological changes, but we haven't noticed any clinical symptoms, and that's really important to notice because it's within the individual. Second of all is that we need to have a strong medical evaluation by physicians and neurologists to rule out other health conditions. We'll talk about those health conditions briefly. And then also using biomarkers to identify whether or not there is any evidence of dementia. So what we also know is that by having this evaluation, it will demonstrate any subtle decline in the individual. And these declines are very subtle. This is the stage that is just slightly beneath normal declines in aging, but it's above MCI, mild cognitive impairment. So, and what it's important to know at this point, it's self-reported. So we're looking at the biomarkers again. So let's go on now to look at what are some health conditions. We know that it's difficult to diagnose the dementia at this point, but it's important to look at some health conditions that may contribute to the dementia-like symptoms. These are some of them that your physician can rule out for your client or the individual you're working with. One is anemia. The second is severe infections. People that have diabetes can have symptoms of dementia. People with kidney disease. We have liver disease, certain vitamin deficiencies, particularly vitamin B12, problems with the heart, blood vessels, and lungs, and also thyroid abnormalities. So these are health conditions. Now you may ask, well, what conditions are out there that individuals may be noticing that would bring them to their physicians or their neurologists? And these are some of the things that have been identified as early warning signs. One is they may start feeling they're misplacing things. Well, I always had my keys. I always knew where to find them. I can't find them anymore. They're having challenges in planning events. They're starting to have some confusions with time. A lot of them may feel that they're starting to have some decrease in their judgment or some poor judgment where they're starting to second guess themselves. They're losing their ability to retrace steps. We see changes in mood and personality. And they may feel there's some memory loss that disrupts daily life. So these are just some things that individuals may sense that are going just not quite right, so that will bring them to their neurologist. So now that we've talked briefly about PCI, let's go on and look at the next stage, which is definition of mild cognitive impairment. Mild cognitive impairment has been defined as the intermediate stage between expected decline of normal aging and the more serious decline of dementia. And when this is noticed by people who have the declines in the following areas. One, they're noticing they're having memory problems, which are more severe. They're having language difficulties. They've got that word on the tip of their tongue, but they just can't finish that sentence. That word's just not showing up. They're also having difficulty with thinking and judgment. So these are the three areas MCI may impact. It begins to impair their normal social and occupational functioning, and they may sense that they're having difficulty communicating, or they're thinking and judgment to the point that they find themselves withdrawing from normal social events. You may have a person who was very active in a club, maybe who was an officer of the club or the treasurer or the secretary, and all of a sudden they're saying, I think I'm going to retire from this position and hand it off to someone else. I've done this long enough. And it's because they're sensing there's difficulties within themselves. Their thinking and judgment may have some issues too. And then we may say, as in the occupational functioning area, that they are really struggling at work, trying to do things that may require higher executive functions, communication with others, following step-by-step directions. Now, the good part about it is when they're doing the diagnosis of MCI, it does not significantly impact daily functioning. And when we're looking at daily functioning, it does not impact those ADLs, the activities of daily living, which means that they are still able to take care of themselves. Dressing is fine, being able to feed themselves, issues with toileting, issues with bathing, those types of things still remain intact. It's more involved with the memory, the language, the thinking, and judgment. And also with MCI, it's more noticeable not only to the individual, but also to friends and family members. So as MCI progresses, we may see some changes similar as dementia, and it may turn into a full-blown case of Alzheimer's disease. But as we can see here, it also has three separate prongs that it could follow. One is, once diagnosed, they may see that the symptoms are going to remain stable multiple years. And there are things that the individual can do to help it remain more stable. The other way it may do, second prong, is that it may progress to Alzheimer's disease or a related dementia. The third is that it may improve over time. And we're seeing it improving over time in some individuals, and the improvement in time may be because there are other factors that are contributing to the MCI. Now, MCI also has two specific types. One type is involves the memory impairment only, or memory impairment plus other domains impaired. And this is then defined eventually as Alzheimer's disease or vascular dementia. The other part two, is non-memory impairment, where it has other multiple non-memory domains that it involves with the individual, such as frontal temporal, Lewy body, primary progressive aphasia, Parkinson's disease, and maybe they're adding in eventually some symptoms of Alzheimer's disease and vascular dementia. So now let's look at some of the symptoms and signs of mild cognitive impairment. So the individual, as we see here, may start having a sense of feeling overwhelmed by making decisions. And it's greater than having difficulty multitasking. It's just hard to make the decision. They're not sure of it. They're having difficulty planning steps to accomplish a task. Their executive function levels really having difficulties, or they can't follow instructions. The second part is some of them may have trouble finding their way around familiar environments. It could be in a building they're getting lost. It could be walking outside in the neighborhood. It could be someone who's driven in the neighborhood for multiple years, but they're getting lost with their driving. The third is they're beginning to show impulsive or very poor judgment and making poor decisions with interacting with others, not being able to take their medications, mismanaging money. So they have a wide range of issues that they're showing poor judgment with. There are additional signs of mild cognitive impairment. One is they forget things more often. And as this lady says, now I thought I knew this, but I forgot it. And this goes even greater. Remember the story of going to the grocery store, they're forgetting those things. They're forgetting their medication. They're forgetting birthdays, anniversaries, things that were important, even some of the routines that they follow at work. They continue to forget events such as appointments or social engagements. And when we're seeing this, these are red flags where family members, friends, if they have appointments with physicians, eye appointments, dentists, business appointments, when they're starting to see a pattern of this, it's a red flag. The sixth area is they're going to lose a train of thought or the thread of a conversation. They're going to be looking at books and they're having difficulty following the storyline through the books, or having difficulties with movies. Some of the additional signs of MCI that we have seen, and part of these can be treated through counseling or medication, are signs of those individuals who have depression. There's some mood and personality changes. Family members may find them to be very irritable. There may be signs of aggression, particularly if you're a family member and you're stepping in trying to correct someone or putting limitations on them or finishing a sentence for them. You may see signs of irritability and aggression. You may even see signs of irritability and aggression because they know there's something going on with their memory or thinking and judgment, and their way of coping with at this point is lashing out. There may be some signs of anxiety, particularly in new circumstances, changes in structure. The anxiety surfacing just because they know things are wrong and they can't resolve it. And last of all is signs of apathy. So let's now look at some of our causes of mild cognitive impairment. One is that they know that there are changes in the brain that are potentially responsible for MCI. Through tests and through research, they have shown that abnormal clumps of the beta amyloid protein in the brain, which is causing plaques, is responsible for part of it. We've seen microscopic protein clumps of tau, which is characteristic of Alzheimer's disease. So all of these have an impact on the brain functioning. We also have Lewy bodies, which are clumps associated with Parkinson's disease and in some cases of Alzheimer's disease. And last of all, there are individuals who have small strokes or reduced blood flow through the brain vessels. So let's take a look at what happens to our brain. As we see, this is a side shot of the brain. And the purple area here in the brain is the hippocampus. And this area is responsible for our memory. Now we know as the disease progresses, the hippocampus shrinks. And as this hippocampus declines in size, it also impacts our memory. The second area is when there's been an MRI, and it has shown what normal ventricles look like. But on your right-hand side here, we see an enlargement of the ventricles, which were due to an increase in the fluid-filled spaces in the ventricles. And as the fluid increases here, it decreases the brain size. The third area that is responsible for MCI is a reduced use of glucose in key brain regions. So the combination of the three impact the brain, which can lead to a diagnosis of MCI. So scientists now have shown that those who have the strongest risk factors for MCI are those individuals who are increasing in age. 15 to 20% of individuals who are 65 and older may have MCI. Also, you're looking at genetic markers, the biomarkers. those who have a specific form of genes, the APOE-E4, are at greater risk for MCI. There are also medical conditions and lifestyle factors that are linked to a risk of MCI. Individuals who are diabetic have a greater risk. Those who are smoking have a greater risk of dementia and MCI. Individuals who have high blood pressure and who don't have it under control increase that risk. Elevated cholesterol, vitamin B12 deficiency, and sleep apnea. So all of these contribute to an increased risk. Now, other conditions that contribute include individuals with depression, those who do not do any physical exercise, those who totally have a lack of physical exercise or limited contributes to MCI. Also, those who have very little mental or social stimulation activities contribute. The other two areas are underactive thyroid glands and the diet. So together we have about 12 different things that contribute. Additional things that contribute include individuals who have a lower socioeconomic group, lower education, and that can be contributed to the lack of adequate funding for a proper diet, and also the lack of stimulation and interaction with mentally and socially stimulating activities. So those who have been identified with MCI, there are observations of changes in the personality, their moods, their memories, their thinking, and it can, some of these perceptions and observations could be identifying and increasing an individual's anxiety level, or even just being sad and withdrawn. The second one is that they may notice some trembling of the individual or some difficulty with walking, so observing an individual's gait is important. Also, looking at hearing or vision changes, with vision being one of the areas that we need to pay attention to when we're doing some diagnosis, because one of them is the difficulty looking, say, at a field. If you picture a formal dining room with a beautiful white tablecloth, the white china, and the white napkin sitting back there trying to look at that field, trying to separate the three items. Others observations include more forgetfulness, more difficulties with their memory, and it's important to note when, as a family member or professional, when you started observing these difficulties and track them. Also, you're going to want to make sure that you're looking at all of the individual's medical conditions and changes in medical conditions, particularly in areas such as being diabetic, if there's any kidney disease, if there's hypertension, if there's cholesterol areas that are being monitored, if there's medication taken, changes in medication, or failure to take medication. And last of all, the importance of getting a complete list of medications, both prescribed and over-the-counter medications. We also know for individuals that are older, there's an opportunity, or I should say some individuals visit multiple physicians, and there's polypharmacy, so we have to be careful for those things. So what happens when we're going to get our diagnosis? When we reach the point that the individual is going to the physician, first of all, he's going to take a thorough medical history. He or she will obtain a thorough medical history. Next, they're going to do an assessment of all of the independent functions and daily activities that they're able to do. It can be things as grocery shopping, driving, executive functions, shopping, and then the daily activities. Third, they're going to be asking for input from a trusted friend, a family member, or a staff person. And then the fourth part is that they're going to be doing an assessment of the medical status of the individual. So let's go on again and look at more what goes on for the diagnosis. When you're completing an in-office neurological examination and a physical examination, your physician is going to look at the individual's reflexes, eye movements, walking, and their balance. They're going to also look at an evaluation of the person's mood, and they're going to do a comprehensive depression screening. They are also going to be looking at potential laboratory tests, including having an MRI done and potentially looking at the biomarkers. And included in the screening, they're going to be doing a mini mental status exam to evaluate the individual. So what they're looking at over these during this exam, they're going to be looking at the memory complaints that the person's putting forward. They're going to be looking at if there's any memory impairment. They're going to be looking at general cognitive function of the individual. They're going to be looking at the daily activities and also other diagnoses such as hypertension, depression, and sleep apnea. Now, once we have the diagnosis, and if there is a positive diagnosis for MCI, the treatment at this time has been recommended of increasing physical exercise. The second is increasing your diet to include a diet rich in food, fruits, vegetables, but also low in fat, providing some type of intellectual stimulation either through games with other individuals or a new hobby. Fourth is increasing some social engagement. And the fifth is doing some memory training. So these are areas for treatment if there is a diagnosis. So as we see today, there's a lot there for individuals. Like we said, the normal memory decline for those who are older include areas, three primary areas of delayed free recall, the source of memory, and prospective memory. But for the most part, as we age, our memory remains intact and stable, that we're able to do recognition, we're able to remember how to do things, the order of doing things, and we're also able to remember temporal memory and the use of time and the history of past events. The other part we addressed today was the definition of pre-cognitive impairment, and this is the stage where the individual notices subtle changes to the point that they're going to the physician, but there's no really outward clinical appearances of changes. The physician's able to check through the use of biomarkers to identify the potential of having dementia. And the third area we talked about was the third progression, which was the MCI, the mild cognitive impairment, where it impairs the individual's memory, language, thinking, and judgment. Some impairment with normal social and occupational functioning, but does not significantly impact your daily functioning. So these are the areas that you can use to observe the individuals you're working with out in the field. Thank you very much.
Well, thank you so much, Dr. Dial. It was such a pleasure. For all of the viewers watching, please view the reference slides that Dr. Dial used for her presentation for any additional information or a closer look at any of her references. I also want to remind viewers that on this last slide is the link to the post-test. We encourage you to take this post-test at your earliest convenience. A certificate can be provided by entering your email address at the end of the post-test. Please remember to view the other webinars in the Dementia Capable webinar series provided by the Rosalind Carter Institute for Caregiving in partnership with the Georgia Division of Aging Services. Thank you, and we hope you'll join us again.